Good afternoon, and thanks, Emanuele. And I'm very happy to be here with all my friends discussing this topic that is very exciting, I agree. And my job, it's very simple this afternoon, because I will just revise with you very quickly why female sex hormones are so important in desire and arousal. And I think everybody knows in this audience that, of course, sexual symptoms, especially if associated with distress, and in this case is the definition of female sexual dysfunction, may occur at any age in a woman's life. But we have this huge study that was able to demonstrate very clearly that when you consider the symptom and the distress and you put together these two concepts, at the time of menopause, you see a significant prevalence of female sexual dysfunction. Anyone, because we know that there is a strong comorbidity between the different disorders, and it's very difficult to think about low desire or poor arousal, poor orgasm in a vacuum. So usually we may have a leading symptom, but then sooner or later you will develop other disorder. And I have to tell you that I discovered so many years ago, thanks to the seminal work of Lorraine Dennerstein back in Australia, that is absolutely normal to observe a decline in sexual function and sexual activity from pre-menopause to post-menopause. This is really life. This is menopause. This is the aging process. There are many things affecting this destiny of the woman, we may say, and even of the couple. But she was smart enough at that time already to demonstrate what we are discussing today, that you have to consider as well partner's health and sexual problem on one hand. You have to consider the feeling for the partner. You have to consider how you enter the menopause, so the value you put before on sexual activity, how much you care about your sexual partner, and very importantly, as Emanuele said, in the system medicine, good physical and mental health. And low sex hormones are very important, but are just one of the pieces of the puzzle affecting the two major symptoms we detect in clinical practice. On one hand, low desire, or low libido, if we want to use this term, and sexual pain, dyspareunia, due to genitourinary syndrome of menopause. Hormones are important. We are at the European Menopause and Andropause Society, and even in the woman, there is this dual concept. It's not only estrogen. We have studied this since so many years. Low estrogen means developing menopausal symptoms. But we have, in the last few years, this new concept that is related, that you have a track of menopause and you have a track of aging as well. And probably aging is driven by an aging adrenal function. So having lower androgen in your body. And we know this. We had even the seminal studies by Fernand Labrie, a very famous endocrinologist in Canada, that he was able really to prove this point, and also all the study that Susan Davis did in Australia to demonstrate over time that when you are 40, you have half of the androgen that when you were 20, and when you are 60, you are half of the androgen that when you were 40. So both these endocrine systems contribute to midlife health and beyond during the aging process. And it's very important we consider this, that it's not only menopause, it's aging, but there are special conditions, for example, the model of surgical menopause, in which this is even worse, because you remove also the amount of androgen that is produced by the gonad. And keep in mind that in postmenopausal women, this is extremely important, this left androgenic function. And so androgen, they are very special because they are precursors even of estrogen into the tissue, and this is the concept of endocrinology that you sure are aware of. And indeed, as everybody probably knows in the audience, but I want to remind you this in light of new guidelines that we produce with the International Society for the Study of Women's Sexual Health. Anna Maria Giraldi was the president, I was the president of this society, a bunch of very good people working in the field. They gave new advice. If it's a good idea, for example, to measure androgen, not measuring androgen in women, to understand if this syndrome that we may define androgen insufficiency syndrome really exists. In my view, we should stick to the clinical diagnosis. We really need to be good doctor, interviewing very well our women, and we recognize that women, they have a more severe climacteric syndrome, more vasomotor symptoms, insomnia, depression, headache. Probably there are also some kind of androgen insufficiency, but most importantly, some cluster of symptoms. They deal with sexuality, motivation, fantasy, enjoyment, arousal, and genital vasocongestion. So we may use the questionnaire, FSFI, we can use a clinical interview, but in a very quick way, we can understand if something going on in a very special way in terms of sexual function. It's not just a little bit of poor desire, a little bit of low lubrication. Is, as my dear friend Alessandra Grazzotin that is here, she said always, my clitoris is dead. It's a very simple definition, but this explains you that something going on into the genital that is quite different than only having poor lubrication. And also you may have some clinical symptoms such as poor muscle mass, poor bone mass, a decline in pubic hair, and overall less quality of life. And as you know, there are many limitations in measuring testosterone in clinical practice. According to the last guideline we released, we said, okay, it's not so much useful to measure testosterone. We can measure testosterone, however, if we decide to replace our patient with this compounded product we have, because unfortunately, we don't have a specific drug for women available everywhere. We had the patch in Europe, but unfortunately we don't have it anymore, and this is a shame, I have to tell you this. And so we used to measure testosterone only to avoid supraphysiological levels, because we really need to put always into the right perspective efficacy and safety. Don't forget that, because otherwise we are lost. And it's important, I tell you, there is no cutoff level. Endocrinologists, they know very well that to diagnose hypogonadism in men, you have a cutoff level that is really validated across the world. We don't have a validated level for women. And indeed, probably testosterone is even not the best hormone to measure the role of androgen in the female body. Indeed, also Susan Davis, but you see, I just shared a piece of my little research in Pavia to show you very clearly that when we consider many factors in affecting the different domain of the female sexual function index response, so the older domain in early postmenopausal, you see that we had some relationship with circulating level of sex steroids. We had a relationship with estradiol, not so strong, but we had a stronger relationship with DHEAS. So the androgen precursors from the adrenal that give also origin to all the other androgen and even estrogen into the tissue. And last point that is interesting, that we didn't find so strong effect of depression, but we found more an effect in that particular category of women at the beginning of the menopause of anxiety, meaning that women, they perform and they are more anxious when they perform. So this is important. We know this, that is relevant for sexual function and behavior, this change of hormones, because we know that the hormonal milieu affects the neurovascular substrate, the neuromuscular circuitries, and overall the well-being of women. And they may affect the sexual response at many levels, desire, arousal, orgasm, and without forgetting intrapersonal and interpersonal determinants. What hormones they do really? This is a cartoon I always show in my talk because I'm not able to improve it, okay? Because I think it summarizes in one what we know. We know that estrogen, they are permitting in the brain some behavior. They are typically female behavior and oriented to sexuality. Testosterone is the really initiator, is the pillar of sex drive, the biological inner force that gives you the energy to enter a sexual relationship that has nothing to do with the intimacy, emotion, and other aspects, and progesterone probably play a role in modulating this. And they have a role in balancing the neurotransmitters, so that nice fix in the brain in which you have a good balance between dopamine, serotonin, we know also noradrenaline, GABA, they play a role. So at the end of the day, sex hormone prime the brain to be selective, responsive to sexual incentives that we may have from the outside, from the inside, imagine fantasies, etc., creating a neurochemical states, likely inducing the sexual response. And this is true also at the level of the genitals. Sex hormones, they do exactly the same thing. They exert a trophic effect and modulate the threshold of the tissue response to external and internal stimuli through our neurochemical array that, as you can see there, is modulated by estrogens, testosterone, progesterone. You modulate sensation, vasocongestion and lubrication, and even the orgasmic platform. But you do that by modulating neurotransmitters, and even molecules that we know so well from the andrological world, such as, for example, nitric oxide and prostaglandins, etc. And indeed, in this cartoon, Shel Kinsberg and Jim Simon, very good friend of mine, they summarize this concept and say, listen, sex hormone change trigger desire and arousal disorder, and there is no separation. It's something occurring in the woman when you have a change with the menopause, because you may affect both centrally and peripherally all the circuitries involved in desire and arousal. Because on one end, testosterone and estradiol facilitate the blood flow and vaginal lubrication, and they facilitate the activity of a specific factor. They may give you more desire, less desire, more or less responsive arousal. And the key neurotransmitters are really dopamine, norepinephrine, and serotonin in this business, okay? So it's very important to keep in mind that without hormone, there is not the anatomical and the functional substrate of the sexual response. And this is the reason why we evolved. We are not talking anymore about VVA alone in a vacuum, but we talk about genitourinary syndrome of menopause, encompassing even other symptoms, sexual symptoms overall, and recognizing both the role of estrogen, both the role of androgen, and even the role of the aging program that we have in our life, and it's depending also from lifestyle factor, as very well Emanuele told to you. We know that estrogen and androgen, they work together at the genital level. They work throughout genomic and non-genomic effect. They work not only on the vagina, but also on the vulva, the urethra, the pelvic floor, etc. And therefore, both these hormones, and probably even the precursor, that is the HEA, play a crucial role, and we really need to try to replace our patient either locally or systemically to obtain a nice response. We have also some kind of separation just for didactic purpose of what estrogen are doing, what androgen are doing, and probably they are working together in influencing all the different components you know so well of the anatomy and the function. We may attribute more or less lubrication, thinning of the vaginal epithelium, and poor elasticity to the lack of estrogen. And we may attribute more vulvar and urinary symptoms and pelvic floor dysfunction to the lack of androgen, especially nerve density, nerve sensitivity, ability to respond. And therefore, I want to conclude by saying that this is important in the context of what we were saying at the beginning. Because, of course, when you have a challenge, an endocrine challenge, you will have a genital, a vascular impairment. But keep in mind that sexual health is a concept that is more broad, and it includes other aspects of well-being and general health, cardiometabolic imbalance, for example, mood disorder and drugs, and you impinge with menopause on all these aspects, and at the same time, if we want to improve this neurovascular and neuromuscular response, we really need to consider and address all the comorbidity. It's not just replacing hormone, and that's it. And therefore, we have to consider this model, the circular model of the sexual response, trying to identify which one is the leader symptom. Maybe it's just pain in the vagina, and that will reinforce the brain, or vice versa. Maybe you have low desire, and you will reinforce the vagina. And we have to consider for sure the partner, because the partner is there and is modulating. Everything is not just a question of having a little vagina. So to conclude, sexual symptoms are very common. Following menopause, we know very well, both estrogen and androgen, along with the aging process, contribute to their clinical manifestation, and we should consider this dimension really in a context of not only sexual health, but general health. Thank you for your attention.